My name is John Murphy, psychiatric nurse practitioner. I'm here with James Kennedy, psychiatric nurse practitioner, and this is Compass Point Institute. This is our first episode. We're just going to jump right into it. James, why don't you take it from here?
So recently, a new article, I think it was published about a week or two ago in JAMA Psychiatry. Actually, the title of the paper was Increased Prescribing of ADHD Medication.
I see. So it's the telepsychiatry.
So I think it's all just focused on telepsychiatry, it obviously aligns pretty well with the boom in telepsychiatry and the increase in diagnosis and prescribing. The large study covers, I think, almost 250,000 patients that take ADHD medications based in Sweden. One thing that I'm always speaking to with my patients, especially when we're considering a stimulant, which, as we know, is the gold standard for ADHD. But talking risks and benefits and informed consent and such, and about the risks that certainly come with medications. And I think
Well, yeah, it's the perceived
yes,
risk,
perceived
like the
risk.
perception of
Yep.
risk.
I've always talked to my patients about it's like, yes, of course, there's definitely an increased cardiac risk. I think left ventricular hypertrophy and other cardiac risks, they're there for sure. But I think looking at things, especially through the nursing lens. So we know patients that aren't receiving treatment for ADHD medications, all-cause mortality is about 10 years less. So life expectancy is dramatically impacted by not taking medications. So
So, what did this study say?
so the biggest takeaways here. So consistent protective benefits were demonstrated. Medication showed statistically significant reductions in serious outcomes across all time periods. There's a really significant improvement in self harm. So 15 to 23% reduction in self harm behaviors. Unintentional injuries, 7 to 13% reduction in traffic crashes, 16 to 27% reduction in criminal behaviors. I think it really speaks to what we have already known, but this fight with the Korean people is really in this current environment where there is just a lot of heat on increased prescribing and increased diagnosis.
Sorry to cut you off, but what was the time frame? Was it because it's
Over
longitudinal? Is it
15 years. Yeah,
longitudinal?
I believe it was over.
15 years. Wow, it's a long time. And how was the data collected? And was it the same medicine or medication sort of regimen? Or
So they recruited about 260,000 individuals. Follow somebody for that long, especially with ADHD, no less. That I think is incredibly impressive too. It doesn't appear to be a drug study, funded by big pharma.
you said it was published in JAMA?
Yeah,
Is it?
JAMA Psychiatry. It looks like it was June. I thought it was June 25th, 2025.
I'd say that everything you said mirrors the things that I see.
Real world risks that go with not actively treating your ADHD.
I get most concerned for myself taking ADHD medication and having ADHD. That makes me the most scared. Being with my family, being with my
So,
kids, going on
yep,
vacation. I'd rather be at work because that's routine
very true.
and
Yep.
these sort of. I think the behavioralism that comes with consistency as well. You're more likely to be able to have habits that are going to help you out without
Mhm.
medication if you're actually consistent with it for any period of time. So there's a weird duality, a sort of irony. But I wanted to ask you, it's like an echo chamber. I know how you are and I know how I am. What can we do? The bias that is present not only in the patients, but in the providers and the institutions. What do we do about that?
Well, I think for this one, I think this both applies to clinicians and to patients. I think I see a lot of patients that do have a concern, like, am I going to become addicted to this drug? The guidance recently, they kind of put stimulants in that conversation with opiates. Didn't say it overtly, but just a lot of concerns that this is the next new wave where, the new opioid epidemic. This is a very different situation where I think honestly, just leaning on this study, it just drives home the fact that individuals engaged in criminal behaviors. They didn't sit here and, as a result of their medication, have a reduction in criminal behavior. That in and of itself, especially from the DA and a criminal justice standpoint,
Right.
it really drives home the point that this is not similar in any way. But I think let's have that concern about being addicted to these medications, being dependent on them. And there's still that stigma that's out there. And I think for clinicians and patients, leaning on studies like this, talking about real world outcomes and really look at things holistically, I think this is a great study to have, especially the breadth of it and not just the length, but just the amount of patients that were followed. I mean, this is huge. Sometimes, especially newer clinicians too, and myself, I think I kind of fell into that trap initially. It's like, okay, well, great. If you can take the weekends off, that's going to buy us more time for tolerance to build. And I think
The myth
short-sighted.
of tolerance,
Yes,
right.
very short-sighted.
Exactly. Yeah. And that, well, that cuts to, I think, a very practical and obvious solution to the provider bias, which is updated pharmacology or recommendations and guidance for effective and optimal pharmacotherapy. I think that's a huge problem. That you can just fill that in, and then we have things that are a lot better. But to play devil's advocate, culturally, we have, caffeine, right? We're in New England, Dunkies, Dunkin' Donuts. America runs on Dunkin'. The distinction here is certainly not similarity in the drug effects of the medicine. It couldn't be more different. You got an upper and a downer. So with opioids, you have a physiological dependency and addiction, whereas with stimulants, it's what's called a psychological addiction. They should not be Schedule 2. But that's maybe a conversation for a different day.
For stimulants might be, a bit high, especially where benzos are lower than stimulants. And we know that the effects of benzo withdrawal are potentially life-threatening, and especially Xanax as much as it's prevalent out there.
Xanax is the one med that I've kind of had the worst experience with, cautiously prescribing it, as I do with all benzodiazepines, because I know that they're not a great tool long term, but they can and should be used in certain situations, in acute situations. But when you have the options that you have, when you go to Xanax, it seems that observationally it's just more addictive. And I've had people go from polite and nice to sort of really angry and wanting
Yeah, I've
more.
actually never initiated a Xanax prescription for flights. I'm like, okay, that's, I don't necessarily have an issue with that. But as far as if I'm the initiating provider, there's never been a Xanax prescription that I've initiated. I tend to prefer Ativan, but again, judiciously. It's not
Well,
sure.
clonazepam too. I use either
Yeah,
Ativan or
depending on the situation, they
clonazepam.
both have really, really solid profiles and benefits. But again, I think you hit the nail on the head. It's short term. It's like this is, through
Exactly.
the roof stressor, especially if we're just initiating an SSRI and we need something to kind of buy us some time. Yeah, I think it's flights. It's like how many people want to do exposure therapy for half twice a year. But most people prefer, okay, I'll take an Ativan, take the nerves away. It's opioids and stimulants. They're very different medications. Looking at a study like this too, these real world outcomes that are tremendously impacted positively by medications rather than vilifying and continuing to propagate like this stigmatization of
Yeah.
stimulant medications, which
Practicing in 4 states, when I think about the DEA as a federal body, the issues that I've had relative to what state I'm in. I know you and I went to a talk a couple of years ago, and you heard these sort of statements made by clinicians. Stimulants can be and are used for performance enhancement. If someone needs a cup of coffee, that's performance enhancement. But we're distinguishing a difference here between someone that if you add medication, their life is better, not someone that reached for a cup of coffee. We got to think of these things in two different ways. So for the individual that is making those statements, maybe for you, it's performance enhancement, but for others, it's being able to actually show up. And let's put it this way. So there's a drug, okay, that can be used for, we're talking about pharmacotherapy for a very specific purpose. We're not talking about the implications of amphetamine or methylphenidate. These are drugs, but when we say ADHD treatment, we're talking about pharmacotherapies. If there is a medicine, it's for a particular person. So when I talk to someone that is asking about the medicines, I'm like, to be honest with you, it's not really the medicine, it's who gets what. James and I just want to talk to the clinicians out there, for the people that are interested in helping others, whether it's nursing or mental health in general. We want to give some advice that we could have had when we got started. So if anyone out there wants to hear us talk about anything, please reach out, let us know.
to really analyzing what's out there and providing our windows of insights that we've gathered over the years. And there's there's a lot of complexity out there, and we're here to kind of help you sort through it and really get to your best outcomes with your patients and feel clinically in a good spot, feel comfortable with your decision making, and making sure that it's sound and based on good data and a good perspective.
Awesome. Yeah, and I'm excited to talk about everything neurodivergence, autism spectrum disorder, trauma, anything that could, befall someone in life, anything that falls under the category of mental health, I think, is on the table.
Absolutely.
I'm John Murphy, psychiatric nurse practitioner.
I'm James Kennedy, psychiatric nurse practitioner. This has been an episode of Compass Point Institute. Stay tuned.